The purpose of this video is to provide enough information in order to make a decision about whether or not to introduce an ECMO service in our institution. It is divided into two parts. The first part is an introduction into ECMO itself. This is necessary in order to decide how and where in our system to house the program should we decide to proceed. The second part delves in some detail into what the service line structure should look like, again, assuming the decision is to proceed. ELSO, or the Extracorporeal Life Support Organization, is an international nonprofit consortium of healthcare institutions who are dedicated to the development and evaluation of novel therapies for support of failing organ systems. One of the primary missions of the organization is to maintain a registry of at least the use of extracorporeal membrane oxygenation in active ELSO centers. It publishes guidelines and position papers and is the de facto international body guiding the provision of ECMO services worldwide. ELSO maintains the ECMO registry. It can also bestow the ELSO Award for Excellence in Life Support. Membership is a must. As evidenced in their mission and vision statement, one of their goals is to provide support to institutions developing extracorporeal life support through continuing education, guideline development, original research, publications, and maintenance of a comprehensive registry of patient data. As mentioned, ELSO is the premier organization providing education, training, research, and data management for the advancement of ECMO throughout the world. In order to be awarded the ELSO Award for Excellence in Life Support, centers have to meet the criteria listed below. According to the ELSO website, corporate membership in 2018 is approximately $3,750 per year. As you can see from this slide, the provision of ECMO services spans a spectrum. Most institutions begin with VA ECMO and VV ECMO. Once they have become proficient in the provision of ECMO services, however, most institutions also expand into ECMO for donation after cardiac death and ECMO for cardiac arrest patients. As you can see at the top of the slide, veno-arterial ECMO is used for acute circulatory failure and veno-veno ECMO for acute respiratory failure. Central to understanding what is required for the provision of ECMO services is an understanding of the ECMO system. ECMO requires that the patient be fully anticoagulated. Blood is pumped from a venous access catheter through a membrane oxygenator, heated, and then returned to either a vein for veno-veno ECMO or an artery for veno-arterial ECMO. Monitoring and adjusting the performance of this circuit is the job of the ECMO specialist. Whether VV or VA ECMO, disruption to or problems with this circuit are immediately life-threatening. Time to correction is generally less than 3 minutes for successful salvage. In all ECMO centers, a full-time employee is required to, quote, sit the pump, end quote, 24 hours a day. As mentioned previously, the two main types of ECMO are distinguished by whether the oxygenated blood is returned to an artery, veno-arterial ECMO, which is used for combined circulatory and pulmonary failure, or to a vein, veno-veno ECMO, for pure acute respiratory failure. It is extremely important to understand that ECMO is a life-saving tool that simply buys time in order to make a decision. ECMO promises circulation and oxygenation. It requires a pump, an oxygenator, and cannulae. It can be done at the ICU bedside, and the goal is to optimize and stabilize end organ function of the liver, the kidney, the lung, and the brain, while the primarily affected organs of the heart and the lung are given time to heal. The first decision in deciding upon providing ECMO support is which type, veno-veno versus veno-arterial. Is there truly a big difference? The answer is, of course, yes, there is a huge difference, and this will be one of the major factors determining where in our system ECMO services would be provided. Veno-arterial ECMO provides full cardiac and respiratory support. Its uses include patients with complete cardiac standstill and refractory arrhythmias. Veno-veno ECMO provides only respiratory support, and it is important to understand that veno-veno ECMO requires a normal RV and LV in order to circulate blood. It does not provide any cardiac support. Therefore, it is good for non-cardiac respiratory failure. It is also important to understand that switching from veno-arterial to veno-veno or veno-veno to veno-arterial is not simple. Therefore, planning is extremely important before placing a patient on ECMO. As noted, veno-arterial ECMO provides full cardiac and respiratory support. Since veno-arterial ECMO requires arterial cannulation, it is technically more difficult than simply cannulating two veins, as is required in veno-veno ECMO. Veno-arterial ECMO provides full cardiac and respiratory support. It requires cannulation of the artery with a large bore catheter. This catheter then occludes flow distally to the limb, and therefore a second smaller perfusion catheter must be placed to supply blood to the lower leg. Failure to place the secondary perfusion catheter will increase the chances of limb ischemia. As mentioned in veno-arterial ECMO, in order to prevent limb ischemia, a second smaller arterial catheter must be placed to supply blood to the lower leg. Some institutions require the venous catheter be placed into the contralateral leg, while others, in order to minimize the risk of both limbs being affected, place both the venous and arterial catheters in the same leg. The limb ischemia, as pictured in the lower right-hand corner of the slide, is one of the dreaded complications of veno-arterial ECMO. In classic veno-veno ECMO, a short outflow cannula is placed into the iliac vein, while a longer inflow cannula is placed right below or in the right atrium. Most institutions require bedside fluoroscopy for the placement of this longer catheter. Catheter placement in both femoral veins is depicted in panel A on this slide. Another commonly used configuration for veno-veno ECMO is that a short inflow cannula is placed into the right atrium through the internal jugular vein, and the long outflow cannula is placed in the IVC through the corresponding femoral vein. In both cases, the placement of the long outflow cannula in the inferior vena cava requires imaging of some sort, generally bedside fluoroscopy, although in some institutions echocardiography is used. Most institutions with a lot of experience in veno-venous ECMO have moved to using the Avalon cannula. It is a combined inflow-outflow cannula that is placed in the right internal jugular vein. The cannula is extremely large and must be positioned so that the inflow ports point directly into the right atrium. It has the obvious advantage of requiring only one cannulation and the placement of one catheter that serves the function of the two catheters previously described. Due to its large size and precise positioning requirements, it is a more difficult catheter to place. This slide serves to provide perspective on the actual size of the Avalon catheter. All of these catheters are percutaneously placed, and the operator placing the cannulas varies from institution to institution. In many institutions, the intensivists place the catheters. In other institutions, the invasive cardiologists place the catheter in the cath lab. In yet other institutions, cardiothoracic surgeons place the cannulae at the bedside. It is important to remember that the indication for ECMO is temporary lung plus/minus heart support. In order to qualify for ECMO services, there must be a reversible disease process in place. There has to be a defined end goal. Often in the case of respiratory failure, this is lung recovery. However, many times in the case of cardiac failure, this service is provided as a bridge to another modality. For ECMO used for circulatory support, as is the case in veno-arterial ECMO, this means bridging to a VAD, ventricular assist device, or transplant. Therefore, in order to start an ECMO service at AtlantiCare, this will require a transfer agreement with a transplant center. Transfer would predominantly be required for the placement of a VAD or for cardiac transplant. Rarely, a patient that is on veno-veno ECMO will not have recovery of their lung function, and a lung transplant may be required as well. To summarize, when the primary problem is a pulmonary problem in a patient with preserved cardiac function, veno-veno ECMO is the modality of choice. Whereas if the primary issue is circulatory failure or a primary cardiac issue, then veno-arterial ECMO is the modality preferred. Common examples of indications for the various types of ECMO are listed in the tables below. Probably the single disease most often requiring veno-veno ECMO is ARDS. For veno-arterial ECMO, the main indications would be acute myocardial infarction with severe damage to the cardiac function, decompensative congestive heart failure, or post-cardiotomy syndrome. These patients are placed on veno-arterial ECMO as a bridge to a ventricular assist device or transplant, as previously stated. Since ECMO is used as a temporizing therapy to A, allow for recovery of the organ, or B, provide a bridge to transplant, then contraindications are sensible. Pre-existing end-stage organ dysfunction, progressive and irreversible diseases, or a contraindication to anticoagulation disqualifies a patient for ECMO services. Another important consideration when deciding whether or not to provide ECMO services is to realize that the patients that qualify for ECMO are often very, very severely ill and stand a very high chance of dying. As you can see from the ELSO guidelines indicated below, when the risk of mortality is 50%, ECMO should begin to be considered, and when the risk of mortality is 80% or greater, ECMO should be initiated. And while the ELSO guidelines stress that there are no absolute contraindications to ECMO, there are conditions that are associated with a poor outcome and can be considered to be relative contraindications. Some examples are listed below. The previous tables looked at indications for ECMO in adult respiratory failure. This one looks at indications for ECMO in adult cardiac failure, and as well provides some of the contraindications that would preclude the provision of VA ECMO in this group of patients. A concept that was discussed at the conference multiple times was that of futility. ECMO is not a cure but a trial, and it was very highly recommended that each institution looking to institute an ECMO service must define criteria for withdrawal when healthy survival is unlikely. Whereas veno-arterial ECMO is used for both cardiorespiratory support, it is a non-pulsatile form of ECMO and bypasses the heart and the lung. In order to help put the various types of ECMO in perspective, ECMO in trauma is predominantly veno-veno ECMO, as the major issue is pulmonary contusions, lung injury, chest wall instability, etc. Whereas ECMO in massive pulmonary embolism is predominantly veno-arterial ECMO, as both heart and lung function is compromised by massive pulmonary embolism. Being able to provide veno-arterial ECMO is part of the treatment algorithm for a pulmonary embolism response team. This graph maps survival in respiratory ECMO or veno-veno ECMO over the past several years. It is important to note that there is a drop in survival at 30 days post-ECMO, and 10% of patients that survive their ECMO experience still expire prior to hospital discharge. Survival in respiratory ECMO is generally greater than survival in cardiopulmonary ECMO. This slide depicts that survival in cardiac ECMO is less than that for respiratory ECMO. These survival statistics were kindly shared by the Jefferson ECMO team. They also represent survival at a facility with a great deal of experience in providing ECMO services. ECMO physiology is complex. The provision of ECMO requires a team that can troubleshoot the patient and the ECMO device and institute changes in medications, adjust the device, or repair and replace components at the bedside in minutes. Veno-arterial ECMO is not complete cardiopulmonary bypass. During partial veno ECMO bypass, blood mixes in the aorta with left ventricular blood, which has traversed the lungs. Hence, the patient's systemic arterial output is the sum of the extracorporeal blood flow plus the amount of blood passing through the heart and the lungs. Understanding and compensating for the uniqueness of ECMO physiology is one of the reasons that an ECMO specialist needs to be at bedside 24/7. For veno-arterial ECMO, understanding the admixture of oxygenated and deoxygenated blood that occurs in the systemic circulation is paramount in managing the patient. As we will see further on in the presentation, there is something called Harlequin syndrome, which can result in cerebral brain death if not noticed and compensated for in a timely fashion. For veno-venous ECMO, it is important to remember that systemic flow is purely native cardiac output and it is unrelated to the flow in the ECMO circuit. There is a time limitation on veno-venous ECMO, generally 15 to 21 days if the patient is femorally cannulated. And in both types of ECMO, local complications such as hemorrhage, embolism, acute leg ischemia, and infection are possible. Stroke, both ischemic and hemorrhagic, is another dreaded complication that can occur during ECMO. The physiology of veno-venous ECMO differs substantially from that of veno-arterial ECMO, and it is important that anyone that participates in provision of ECMO services understands the different physiological components. Some of the major physiological differences between veno-arterial and veno-veno ECMO are displayed in the table below. Understanding these different physiological effects is a requirement for anyone that participates on an ECMO service. Thus, maintaining competencies becomes a major consideration when thinking about providing an ECMO service. One of the major goals of ECMO is the provision of systemic oxygen delivery. While most intensivists understand the basic equation of oxygen delivery, the ECMO specialist has to take into consideration the additional effects provided by the ECMO process itself. Standard critical care principles apply, including that of decreasing oxygen consumption. Therefore, in most cases, critical care physicians are in charge of the ECMO service. The saturation of venous oxygen is one of the most important indicators of oxygenation status on a VA ECMO patient. One requirement for the VA ECMO machine being used is its ability to monitor SpO2 continuously. Anticoagulation is a requirement in ECMO, and meticulous anticoagulation is indicated to decrease the risk of thrombosis and bleeding. The current gold standard is the ability to measure very quickly anti-factor Xa. ACT is not the best monitor of heparin therapy, but that is what is currently used here at AtlantiCare, period. We would need to develop the capacity to measure and quickly report out anti-factor Xa if we wish to pursue an ECMO service. This would be an additional cost that would be required in order to establish an ECMO service. One of the biggest considerations in providing an ECMO service is having at the bedside the ability to respond to an emergency. Providing ECMO services requires an ECMO specialist, quote, sit the pump, whether veno-venous ECMO or venous arterial ECMO. Disruption to or problems with this circuit are immediately life-threatening. Time to correction is less than 3 minutes for successful salvage in most circumstances. Although humorously displayed in this slide, the ability of the bedside ECMO specialist to troubleshoot oftentimes makes the difference between having a successful or unsuccessful ECMO program. ECMO patient complications are associated with significant increases in morbidity and mortality. The ECMO specialist must be able to differentiate whether the complication is related to the underlying pathology requiring ECMO in the first place. The ECMO specialist must be able to respond to bleeding, whether it's from the cannula site, the surgical site, GI bleeding, pulmonary bleeding, etc. They also have to be able to address loss of perfusion to the cannulated leg. They have to have the ability to treat seizures and infarctions, to manage renal failure, infection, and cannula occlusion, to name just a few. With respect to ECMO complications, prevention is the key. But when a complication occurs, the key to solving the problem is determining whether or not the problem is with the patient or the pump, and whether or not the issue is specific to veno-arterial physiology or veno-veno physiology. The ECMO specialist is expected to be able to handle cardiac arrest, deal with hypoxia and determine the differential diagnosis, deal with hypercarbia, bleeding, hemolysis, equipment and electrical failure, be able to manually operate the pump, to be able to understand the pump alarms, to be able to deal with pump head disengagement, air embolism, and accidental decannulation, again, just to name a few of the possible complications that can occur when we are providing ECMO services for a patient. The ECMO specialist tasked with sitting the pump has to be able to manage the complication. They have to have their sequence of responses become automatic and ingrained. They need to call for help, be able to clamp off the circuit, turn off the pump, provide CPR, establish alternative modes of ventilation and inotropic support, administer volume, apply pressure in the case of a cannula being dislodged from the arm or the leg, or prepare to open the chest if the cannulation is central. In other words, they have to be able to fix the problem. Depicted in this slide is one of the biggest concerns that can occur while sitting the pump, and that is the introduction of air into the circuit. In the top two pictures of this slide, there is air seen to be introduced into the oxygenator, which is the blue diamond-shaped structure in that circuit. If air is displacing blood, then the blood cannot be oxygenated or pumped back into the patient. In the picture at the bottom left-hand portion of the slide, we see air in the tubing, which of course can produce embolism. In the middle bottom portion of the slide, we see air has been introduced into the pump. A large enough bolus of air will stop the pump from functioning. And in the far right bottom, the most dreaded complication of the introduction of air into the circuit is that it makes it through the circuit into the patient, resulting in significant morbidity and mortality. Depicted in this slide are catastrophic disconnections with the introduction of massive amounts of air into the oxygenator. The unfortunate patients attached to these devices expired from massive air embolism. Limb ischemia is another complication of ECMO that results from the placement of large bore catheters into the blood vessels of the lower extremity. Placing a backflow cannula reduces the amount of limb ischemia that can occur, but complicates the insertion of the catheter. Even with the placement of a backflow cannula, limb ischemia can still occur, however, it tends to be less severe. Other complications that can occur are kinking of the cannula. Another complication is left ventricular distension. Remembering that ECMO is only partial bypass, there must still be residual right ventricular output, and the left ventricle must also eject blood in order to avoid pulmonary hemorrhage and thrombosis. In order to assess for left ventricular distension, daily echocardiography is often employed. Despite systemic anticoagulation, clots are a frequent occurrence. If clots occur in the oxygenator, it can impair efficiency and ultimately will require that the oxygenator be switched out for a fresh unit. If a large clot occurs emergently, the ECMO specialist sitting the pump at the bedside must have the ability to replace the oxygenator emergently. In a similar fashion, clots can also occur in the pump head, impairing its efficiency or, in some cases, resulting in pump failure. Once again, the bedside ECMO specialist must have the ability to be able to replace the pump head in an emergent situation. There is a very specific complication that can occur with the use of veno-arterial ECMO, and that is a neuro issue. It is in consideration of this issue that cerebral oximetry becomes a mandatory monitoring device when we are using veno-arterial ECMO. In veno-arterial ECMO, paradoxically, as the heart begins to recover, the increased cardiac function results in deoxygenated blood being pushed into the proximal aorta and thus feeding the great vessels that supply the brain. This produces what is known as the Harlequin syndrome. There is flow competition in the aorta as the recovering heart begins to fight the effects of the ECMO pump. Since pulmonary function is generally impaired, we get the occurrence of a blue head and red legs. Deoxygenated blood is directed toward the brain, and the brain can suffer irreversible and permanent injury, leading to brain death. The ECMO specialist must therefore be able to interpret what it means when there is low cerebral saturations. This may reflect increased brain activity in which sedation must be increased, or it may represent decreased perfusion, in which case we must increase the blood pressure, oxygenation, and hemoglobin. And if none of those measures work, then a head CT needs to be immediately available, preferably in the ICU. In this case example of bilateral low cerebral saturations, transfusing blood, which increased oxygen carrying capacity as well as systemic perfusion pressure, resolved the problem. In this example, there was unilateral low cerebral saturation that required an immediate CAT scan. Unfortunately, in the case of this patient, deoxygenated blood was allowed to perfuse the brain for an extended period of time, resulting ultimately in brain death. Because of the possibility of complications like those previously described, an accessory cart must be readily available in close proximity to the patient undergoing ECMO services. Many institutions keep prime circuits available at all times, as well as having another ECMO device within reach. Once off ECMO, these patients often require a great deal of additional care, and it is also important to realize that 10% of post-ECMO patients will still die while in the hospital. Now that we've completed our review of the different types of ECMO services that are possible to provide, as well as some of the complications that can occur, let's deal with some of the practicalities of instituting an ECMO service at AtlantiCare. Perhaps one of the most important choices is which console are we going to purchase. The console consists of the oxygenator, the blender, the pump head, the tubing pack, the cannula, and the accessories. We have decided that Maquette's CardioHelp is probably the best product on the market at the current time, and it is the one that most institutions are currently using or plan to purchase. In order to get a ballpark estimate of what pure equipment costs would be, I did have the CardioHelp people provide us with an initial estimate for the purchase of 2 CardioHelp consoles and the required supporting equipment as well as the cart. Ballpark estimates of providing 2 consoles is in the neighborhood of $300,000. The configuration as priced would look something like this depiction. This particular device has virtually all of the required monitoring and sensing capabilities that are required for the safe provision of ECMO services. There are oxygenator and pump combinations in the market that appear to be less expensive, but by the time you add all of the required sensing devices and auxiliary equipment, the price differential is significantly less. And this device is the one that is preferred by experienced ECMO centers. Tubing packs come as a standard preparation or can be customized to the individual institution's requirements. Most places begin with a standardized pack, and then as their practice evolves, they are able to configure a customized pack, which is then placed into use. A wide variety of cannula must be available, including cannulas for both femoral, jugular, and central cannulation techniques. Depending on whether veno-veno or veno-arterial ECMO is chosen and the cannulation sites, different cannulas are required to accomplish the goal. This then requires an investment in different sizes of cannula and different types of cannula that will need to be kept in stock at all times. As previously discussed, an emergency cart must be available at the bedside for every patient undergoing ECMO services. Some common contents of such a cart are listed in the table below. If we do decide to become an ECMO provision center, then transport considerations also must be considered. A transport team must be available 24/7, and investment in a transport ECMO device would have to be factored into the equation as well. In addition to understanding what is required for the actual provision of ECMO care, economics and program development must also be considered. In considering the economics, one important factor would be how many other providers are there in the region. In looking at the ELSO registry, the southern New Jersey territory appears to be relatively wide open at this point, with the exception that Cooper Hospital has resurrected their ECMO program. Their initial program was closed 5 years ago. However, representatives from Cooper did attend the same conference that we did, and they are beginning to provide ECMO services at this time. However, they have no interest in becoming an ECMO referral center, according to the physicians who participated in the conference with us. An estimate for initial equipment costs has already been provided previously and is in the neighborhood of approximately $300,000 to purchase 2 devices. Not included in that price is the purchase of a warmer, which would be an additional charge. The most substantial costs would be employee costs. A coordinator is a must if we are going to start an ECMO program. At Geisinger, they have treated approximately 30 patients in the past year. Their core team consists of 3 intensivists, the coordinator, as well as 22 RT/RNs who make up the ECMO specialist team at Geisinger. Their coordinator, Evan, has graciously agreed to come down and assist us if we decide to set up our own ECMO program. Program maintenance costs would be the usual staffing costs and the costs associated with keeping up people's skills, ongoing education and replacement training, whether or not we would have a differential pay or a call pay schedule. There would be the associated equipment costs for disposables such as the packs, oxygenators, pump heads, tubing, and all of the materials required to be in the accessory cart that should be at the bedside of every patient undergoing ECMO. Additionally, there would have to be consideration in how the patient gets charged, whether or not it's a single daily cost or an itemized service provision model. The discussion about who will cannulate the patient is an important discussion that needs to occur. In terms of who will manage the circuit, that is almost always an ECMO specialist who sits at the bedside. In many models, that is a combination of RNs and RTs with specialized training. With respect to who will manage the patient, in most institutions, that is a group of intensivists who specialize in the provision of ECMO services. If AtlantiCare decides to proceed with the provision of ECMO services, then Dr. Adams, Dr. Severaman, and Dr. Bonsall at the very least will need to complete the ECMO specialist training in order to be able to provide 24/7 coverage for patients undergoing ECMO services. One thought that was a constant is that residents are not able to provide this level of coverage. In institutions with cardiology, pulmonary, or critical care fellows, those individuals may participate in managing the patient. With respect to provider charges for the provision of ECMO services, the codes listed below are the ones commonly used, and I took the liberty of providing the Part B Medicare fee schedule for the corresponding codes, so that some idea of what physician reimbursement would be. We would have to acquire from finance what the institutional reimbursement charges might be in order to get a full picture of the economic benefit of providing ECMO services. The CPT codes listed in this table are also utilized in the provision of ECMO services and may represent additional possible revenue from the provider side. Here is the corresponding Part B Medicare fee schedule for 2018 for the CPT codes listed on the previous slide. Some less frequently utilized ECMO codes are displayed in this table. The items listed in this slide are perhaps among the most important for us to discuss. If patients are going to undergo veno-arterial ECMO as a bridge to other cardiac services, would therefore the service best be provided at mainland? On the other hand, since the vast majority of patients are veno-veno ECMO patients for respiratory failure, would that best be served by being provided at the city division? Would we be considering providing ECMO services at both divisions, or would we concentrate it in one division? If so, then interfacility transportation must also be considered when setting up the service. Obviously, other service providers would be required to interface with the primary ECMO team. If we decide to proceed with an ECMO service, then the issues discussed in the next two slides would involve participation by those in the finance department. They would have to provide some sort of assistance in how we would assign indirects. They would be able to provide us with some data on what the payer mix is and what cost center this service would be funded under, as well as whether or not they would charge by the ECMO hour or the ECMO day, and whether or not the length of stay would include issues such as rehabilitation. As with the provision of all services, charge capture is a very important part of a success of an ECMO program. Tracking all referrals, all procedures, all charges, and monitoring documentation would be important elements of a successful ECMO program. In doing research on the economics of an ECMO program, the specific MSDRG that has been developed for ECMO is 003. Deciding on whether or not an ECMO program will be profitable is to understand what the current payment length of stay is for some of the various providers in our region. Blue Cross provides for 45 days of ECMO, Medicare 31 days, Medicaid 43 days, and private payers depend obviously on the contract. Having said that, everyone that we spoke to at the conference was clear that ECMO is a moneymaker, generally speaking, for their institutions. As with the provision of any service, billing is important. Documentation templates need to be developed. Appropriate CPT codes and ICD-10 diagnoses need to be documented, and there will need to be a discussion about who charges for what and what billing method will be used to capture these charges. Much of this is common sense and already in place. Some details that would need to be sorted out should we decide to proceed with the provision of ECMO services is who charges for what specific service. As you can see in the table below, this can be divided up any number of ways. If we decide to move forward, choosing the members of the ECMO team will be of the utmost importance. After the ECMO medical director and co-directors are appointed, strategic planning meeting with physician group representatives, as well as the hiring of an ECMO coordinator and meeting with ancillary service directors would be paramount. If we decide to move forward with an ECMO service, then an ECMO team must be constructed, and what is listed below is generally the configuration that most institutions have found to be successful. The model very closely resembles the way that the neurosciences service line is organized, and therefore would be familiar and easy to accomplish. The key components of this model are, of course, buy-in by administration and the provision of adequate resources to get this program off the ground, the hiring of an ECMO coordinator to work with the medical director, the training and staffing of ECMO specialists to be able to provide 24/7 bedside monitoring of the ECMO circuit and the patient, as well as the recruitment of intensive care providers who would make up the core of the ECMO attending service, and the provision of required support services from all of the ancillary departments. As touched upon briefly previously, we would have to make a decision about whether or not there would be one centralized designated location or whether we would provide this service in both of our ICUs. Additionally, the location of the patient at the time of cannulation needs to be considered, as availability of equipment and supplies, as well as a skilled operator who can place a cannula, must be determined ahead of time. The provision of ECMO services is a resource-intensive endeavor, and all of the specialties listed in the slide below need to be participatory. Choosing a medical director for the ECMO service line has the same considerations as in choosing any medical director. That person needs to be board certified in one of the appropriate specialties, has the overall responsibility for the operation of the program, the development of policies and procedures, the ensuring that all people who participate in the ECMO service adhere to the protocols and guidelines. In addition, they would supervise the other providers providing the ECMO service and lead the case review and other quality measures. In addition, the medical director will determine the program's policies, such as ECMO patient selection and evaluation, determine the protocols for patient management, and very importantly, participate in futility and end of ECMO provision discussions. The medical director will also participate in equipment purchases and what types of disposables are used. They would also play a key role in education for all of the providers involved. As with the neurosciences service line, the medical director would work very closely with the program director or coordinator to nurture further program development, participate in case review, deal with specific patient management issues such as patient selection, assist in the education, assist in the quality endeavors, and assist in data collection and statistical analysis. Choosing the coordinator for an ECMO program is probably one of the most important decisions that would need to be made. Generally speaking, this person is a registered nurse, a respiratory therapist, or a clinical perfusionist that has a strong ICU background and preferably comes with ECMO experience. This individual, of course, has overall responsibility for all clinical and administrative aspects of the program. Additional responsibilities of the coordinator are listed below. Among the most important are that the coordinator ensures competency, has troubleshooting and emergency skills, and is able to understand and appropriately staff for the provision of ECMO services. Additional characteristics of the ideal coordinator are listed below. One of the major functions that the coordinator provides is that of an educator. We would need to decide whether we would provide our own in-house education or whether we would send all of our ECMO specialists to get their training outside of our institution. The coordinator could also help decide who among the current staff would become the ECMO specialist, whether it would be RTs, RNs, a combination of those, or some other solution. The coordinator would also be responsible to educate the bedside staff who are not ECMO specialists but who would participate in the care of an ECMO patient. In most institutions, the coordinator is charged with developing both the initial education program and the orientation process, as well as developing annual competencies. As with the neurosciences program, the ECMO coordinator would be responsible for data collection. They would have the additional responsibility of making sure that all patients that underwent ECMO would be submitted to the ELSO registry. Other standard additional duties of any coordinator are as listed below. When considering the ECMO team composition, these are some of the factors that are involved. In speaking with members at the conference, it appears that the New Jersey state law requires that a perfusionist initiate and discontinue ECMO, as well as be available 24 hours a day in-house. As previously stated, most institutions that provide ECMO services require that an ECMO specialist be staffed one-to-one for any patient undergoing ECMO, whether veno-venous or veno-arterial. As previously discussed, the ECMO specialist is the first-line caregiver to assess, correct, manage, and prevent emergencies, issues, and problems on an ECMO pump. The proper staffing ratio is generally determined to be 1-to-1. That ECMO specialist may be an RN or an RRT. However, in order to be able to intervene quickly enough, they may not have any other patient care responsibilities. The traditional ECMO team consists of full-time dedicated FTEs that provide 24/7 coverage. This team has the skills to prime a circuit, initiate ECMO, and discontinue if required. They are also capable of troubleshooting and providing emergency intervention. We would additionally recommend that all of our critical care APNs become ECMO specialists as well. They would not be full-time dedicated to the ECMO service, but would be able to provide additional assistance in the case of an emergency. In the so-called traditional ECMO team, there is a full-time employee dedicated to monitoring the ECMO circuit as well as the patient, and then the bedside RN who is responsible for providing the medical care and assisting in an emergency. There is also a role for a part-time employee with respect to providing ECMO services. These FTEs are only associated with pump time, provide staffing support to the full-time team, and their time can be allocated as part of existing unit duties or as members of an on-call schedule. To reinforce, an ECMO specialist is the cornerstone of a successful ECMO program. That individual has advanced competencies in ECMO education, CVVH education, as well as potentially alternative modes of ventilation. The ECMO specialist manages the patient hour to hour, and that management includes hemodynamic monitoring, supervising laboratory draws and interpretation of the values. They are the ones who administer medications, make sure that the heparin is appropriate for the degree of anticoagulation required, and must be able to administer blood products, etc. Their most important function is that of troubleshooting, and they need to have the immediate intervention skills with the pump and circuit in order to troubleshoot patient emergencies. As every instructor during the course stressed, it's not if, it's when a disaster is going to happen. In all institutions providing ECMO services, an advanced technology specialist is a part of the team. This is usually a perfusionist. If there is a patient on an ECMO circuit, then a perfusionist must be available 24/7. New Jersey state law requires that a perfusionist be the person who primes the ECMO circuit and who initiates ECMO therapy. In addition, they are an invaluable resource for making sure that everyone maintains their competencies with respect to circuit procedures, such as priming the pump head, changing out the oxygenator, etc. They also assist in patient management issues with respect to educating about activated clotting times, bleeding parameters, etc. They also assist in transport and with discontinuation of ECMO services. I think it is abundantly clear by now that patients who require ECMO services are very critically ill. It is not uncommon for a patient to require renal replacement therapy in addition to their ECMO, or possibly even an intra-aortic balloon pump, Impella device, or other life-sustaining therapy. Space considerations thus come into play when considering the location for the provision of ECMO services. It is important to establish at the very onset of an ECMO program who is in charge with respect to the medical management. We envision this to be the ECMO attending on-call, which we feel would most efficiently be filled by a subset of the intensivists becoming the ECMO specialists. This is the model most commonly employed in most ECMO programs. The specific group of physicians are generally ICU attendings who have received specific ECMO education. Part of their responsibilities would be to triage patients, identify potential candidates, and determine eligibility in consultation with the director. They must also be able to provide hour-to-hour management and support the ECMO specialist who is at the bedside. They must also have competencies with respect to the ability to prime a circuit and with respect to circuit management. Critical care APNs and nurse practitioners would also be required to become ECMO specialists. They would be able to provide an additional layer of expertise and safety. Before rolling out an ECMO program, there would have to be education and buy-in from all of the services listed below. Additional important members of the team would include members from all of the departments listed on this slide. The amount of preparatory work before accepting the first ECMO patient should not be underestimated. Numerous protocols in great detail need to be developed. Order sets covering a wide variety of topics, including cannulation and decannulation, daily and standing orders, and special procedures need to be in place, as well as checklists for shift change and for transporting a patient, parameter summary sheets, and flow sheets. All need to be developed and in place. Completing the picture would be the requirement for regular meetings between the coordinator, medical director, managers, and administration. Meetings with the team for the purposes of education, to in-service the team, for policy and procedure review, and of course for case presentation in order to improve our services. This service would also require a morbidity and mortality review of all cases and all complications, with ongoing amending of the protocols as required. All of this education, of course, must remain in compliance with the ELSO guidelines that are continually updated. What is also very clearly evident is that water drills and simulations make up an important part of maintaining competencies. We would need to be able to set up our sim lab to simulate an ECMO circuit and patient care provision, and have everyone regularly practice what is required to respond to various types of circuit and pump emergencies. We would also have to develop a protocol for evaluation of our specialists that include either a written evaluation or a combination of a written and oral examination. In addition, there would be continuing education requirements for specialists, including attendance at formal team meetings, water drill attendance and competencies, an annual examination, and some sort of criteria for minimum pump hours. Ultimately, we would move to institutional certification of specialists who would be able to complete our own in-house ECMO training course, pass an oral or written exam, and we would have to develop criteria for who could be an ECMO specialist. This would likely include some ICU experience, as well as mandatory other certifications such as BLS, ACLS, etc. The ultimate goal would be that within 5 years we could become an ELSO Center of Excellence. After reviewing the material in this presentation, I believe that we would have enough information to sit and decide whether or not we want to continue moving forward in the development of an ECMO service.